Assalamu alaikum. I'm Professor Dr. Haidar Jawad Mubarak. This is a presentation to practical aspects for anatomy of the intestine, both the small and large intestine, and also anatomy of the liver and bile, extrahepatic biliary apparatus. Starting with the intestine, and specifically I will start with the small intestine. The small intestine is formed of the duodenum, then jejunum, and then the ileum that opens into the cecum. And of course the cecum is the large intestine. So duodenum, jejunum, and ileum are parts of the small intestine. The jejunum had been discussed with the presentation of the duodenum. We have to say now that the whole length of the small intestine is about 6 meters. 25 centimeters of this only is for the duodenum, the rest is for the jejunum and ileum. The jejunum is about 2/5 of the small intestine, and the ileum is about 3/5 of the small intestine, and both are mobile, the jejunum and the ileum, because they are suspended by mesentery of the small intestine. The inside, the mucosa of the small intestine shows circular folds that are called plica circularis, or are called valves of Kirk-rings. These circular folds begins in the second part of the duodenum. They are not seen in the first part of the duodenum. You can see that the first part of the duodenum have smooth mucosa with no circular folds of plica circularis. And this is an important feature that is appearing in barium swallow or barium meal radiological examination in form of a smooth triangular region called duodenal cup, representing the smooth inside of the first part of duodenum that is colored by barium. So the first part is smooth, while the second part starts to show circular plica circularis, or folds called valves of Kirk-rings. These valves of Kirk-rings increases in the duodenum as you are going after the second part, the third part, and increasing much in the jejunum. But actually the circular folds decrease in the distal jejunum, and also decrease more in the proximal ileum, and in the distal half of the ileum maybe they are absent. The distal half of the ileum, which is absent, which shows absence of plica circularis, shows circular patches in the mucosa, which are lymphoid aggregates that are called Peyer's patches. These lymphoid aggregates are also present in the wall of the small intestine, the proximal ileum and else, but they are not seen because of the plica circularis folds covering them or disturbing the vision of them. But in the distal half and the distal parts of the ileum, because the plica circularis are absent, so you can see easily the Peyer's patches, which are circular patches of lymphatic aggregates. If you look to this figure, you can imagine that it is difficult. This is the duodenum, and this is the jejunum and then ileum. It is difficult to differentiate the jejunum from the ileum. But I will show you in table what is the difference between the jejunum and the ileum. The jejunum is located in the upper left side of the abdominal cavity, while the ileum is in the lower right side of the abdominal cavity. If you catch the jejunum by your fingers, you will feel that it is thick, but the ileum is thinner. And actually, the thick jejunal wall appear just like a double sleeve, just like you are feeling the jacket, and deep to the jacket is the shirt. Third point is that the jejunum have much blood supply, so it is red in color, while the ileum is less blood supply and it appear pale in color. Plica circularis from inside are much more in the jejunum and they are less in the ileum. Pire patches are absent or could not be seen in the jejunum, but they are present in the ileum. The mesentery suspending the jejunum contains less fat in comparison to mesentery suspending the ileum. The last point of difference between the jejunum and the ileum in consideration to arterial arcades, and I will need to go to the figure that I have shown you before a while about arcades and vasa recta to show you what is the difference in the arcades and the vasa recta between the jejunum and ileum. You can see that here this figure shows dissection into the mesentery. We had removed one layer of the mesentery of small intestine to show you the superior mesenteric artery. The superior mesenteric artery is a branch from the aorta, crosses the third part of duodenum, and at this region it enters the root of mesentery of small intestine. You can see that this superior mesenteric artery gives many branches from the left side, which are jejunal and then ileal branches. These branches are running straight, so are called vasa recta. But soon they will anastomose with each other, forming arches that are called arterial arcades. And also these branches give another straight arteries from the arches, which are called also vasa recta. Actually, these are the vasa recta that I'm talking about, the branches from the arch. So branches from left side of superior mesenteric artery are jejunal and ileal branches. But these jejunal and ileal branches anastomose with each other, form arterial arcades. The arterial arcades gives vasa recta. You can see that the arcades to the jejunum from jejunal branches are one or two, but the arcades in the ileum are more than one. And the vasa recta from the arcades of the jejunal branches are very long, because the arcades are one or two, and so they are away from the wall of jejunum. Therefore, the vasa recta has to run to a long distance, so the vasa recta are long and they are a few. But the arcades of the ileum, which are many, shows short vasa recta, which are numerous, much numerous than vasa recta of the jejunum. That's why the last difference suggests that in the table, arcades in the jejunum are 1 to 2 with long few vasa recta, but arcades of the ileum are 3 to 6 vasa recta, short and numerous. These are the most important points about the anatomy of the small intestine. Regarding anatomy, practical aspects of anatomy of the large intestine, first we have to enumerate what are the parts of the large intestine. It is the appendix, cecum, ascending colon, then after the hepatic flexure, transverse colon, which is hanging down, splenic flexure of the colon, that is higher than the hepatic flexure. The splenic flexure is on the left while the hepatic flexure is on the right. And then descending colon, then S-shaped sigmoid colon, rectum and anal canal. As you can see in the figure, that the large intestine shows a longitudinal band that represents the longitudinal muscle in the wall of the large intestine. In the large intestine, the longitudinal muscle do not surround all the wall of the large intestine. The longitudinal muscles of the wall of the large intestine appear in form of bands that are called tinea coli. And you can see three bands, one anterior and two posterior bands of longitudinal muscle, or three bands of longitudinal muscle tinea coli. These bands begins in the cecum at the root of the appendix. The appendix does not contain longitudinal band because the longitudinal muscle in the appendix surround all the wall of the appendix. They not form three bands, but the three bands are formed at the cecum, at the root of the appendix, and then these three bands continue in the cecum, ascending colon, transverse colon, descending colon, sigmoid colon. But again, in the rectum there is no tinea coli because here in the rectum the longitudinal muscles surround all the wall of the rectum. These longitudinal bands, the tinea coli longitudinal muscles, are shorter than the length of the large intestine, and that's lead to formation of lobulation of the large intestine. You can see that the wall of the large intestine is lobulated, or sacculation of the large intestine. Also, you can see that the wall of the large intestine shows many bags of peritoneum, or sacs of peritoneum, that are filled with fat, and these sacs or peritoneum or bags are called appendices epipleuecae. These bags are not seen in the cecum, are not seen in the appendix, are not seen in the rectum. So tinea coli are found in all the large intestine except the appendix and rectum, while the appendices epipleuecae are seen in all parts of the large intestine except the cecum, appendix, and rectum. Usually during surgery, especially when there is an obstruction to the intestine, small intestine for example, you will not be able to differentiate between the small and large intestine. So in that case you need also points to be remembered. The small intestine does not have the bags of appendices epipleuecae, but they are present in the large intestine. The appendices epipleuecae are present in the large intestine, not in the small intestine. Tinea coli are present in the large intestine. They are not seen in the small intestine, and sacculation is a feature of large intestine, not in small intestine. In addition to the feature of empty large and small intestine, if you have empty small and large intestine, definitely you will see that the large intestine is wider than the small intestine. Actually, the tinea coli have something important in surgery. If you have a small incision at the right iliac fossa, which is called McBurney incision, and you want to, through this opening, to remove the appendix because it is inflamed, you can open here in the right iliac fossa the McBurney incision midway between the anterior superior iliac spine and the umbilicus, and through this small opening of the incision you will find the tinea coli on the cecum, and then you will follow the tinea coli, and the tinea coli will make you reaching the appendix, because the tinea coli begins at the root of the appendix, where the appendix is attached to the cecum. So the tinea coli is used during appendicitis, during the operation for removing the appendix, and that through the McBurney incision you will follow the tinea coli to the root of the appendix, then finding the appendix to remove it. Here also we have to describe a point which is related to appendix, to the inflamed appendix, which is Meckel's diverticulum. If you go back to your information about anatomy, you find something which is called yolk sac stat or vitelline duct or vitello-intestinal duct or omphallo-mesenteric duct. This duct must obliterated during development. But if it is not, it will remain and it will form a diverticulum which is called Meckel's diverticulum. This diverticulum looks just like the appendix, a blind loop. And this diverticulum is seen in 2% of population. Of course, it is high rate, 2%. It is 2 inches in length and it is present about 2 feet from the junction of the ileum with the cecum, the ileocecal junction. So if you have a patient having pain in the right iliac fossa, pain of acute appendicitis with tenderness, rebound tenderness, and you open the McBurney incision to remove the appendix, which is an incision in the right iliac fossa, midway between anterior superior iliac spine and the umbilicus, but unfortunately you find the appendix is normal, it is not red, inflamed. So please remember the Meckel's diverticulum. It may be inflamed, called Meckel's diverticulitis, but giving the same clinical features as the appendix. So look for it, please, before going up and closing the abdomen. The inside of the cecum shows the opening of the ileocecal junction. This opening is guarded by a mouth-shaped or a lip-shaped valve, which is called ileocecal valve. It is formed by upper lip and lower lip. Sorry for that disturbance. The mouth is guarded by upper lip and a lower lip. The lips are connected by frenulum. And below this ileocecal valve is the valve of the appendix, or the opening of the appendix. Both the ileocecal and the appendicular orifices are located on the posterior medial aspect of the cecum. This is all in consideration to the large intestine. And now I will talk about practical aspects of anatomy of the liver. The liver is a wedge-shaped or pyramidal organ. Surface anatomy of the liver, it lies in the 9 region, in the right hypochondrium, epigastrium, and the right lumbar region, and it has 2 surfaces, as you can see. The anterior and superior surface is related to the diaphragm and is convex, and therefore it is a smooth surface, smooth antero-superior surface, which is called diaphragmatic surface. This surface contains the falciform ligament, which is a double fold of peritoneum extending from the anterior and superior surface to the anterior abdominal wall and the diaphragm. The lower border of this falciform ligament shows the ligamentum teres, that is the obliterated left umbilical vein. In addition to this anterior and superior smooth diaphragmatic surface, the liver has a visceral surface which is not smooth, it is irregular. Of course, the smooth antero-superior surface is covered by peritoneum completely. The other surface, which is irregular surface, is called visceral surface because it is related to some viscera. And this visceral surface, the irregular surface, is inferior and posterior. Actually, it is also covered by peritoneum except of a small triangular area posteriorly that is called bare area of the liver, in which here the right lobe of the liver is directly attached to the diaphragm. This triangular area of the bare area of the liver is limited above by superior coronary ligament, below by the inferior coronary ligament. The apex is the right triangular ligament, and the base is the inferior vena cava. Of course, the coronary ligaments and the triangular ligaments and both the right triangular at the apex of bare area and left triangular are reflections of the peritoneum surrounding the liver, which is visceral peritoneum, reflections of peritoneum from the liver to the diaphragm to suspend the liver in its position. You can see that the inferior vena cava is lodged in a groove on the back of the liver at the base of the triangular bare area. If you will open the liver, the inferior vena cava, you will find that the inferior cava from inside shows many openings that are openings of the hepatic veins. These hepatic veins open directly from the liver into the inferior vena cava. They don't have extra hepatic course. We call this posterior and inferior surface visceral surface, that is irregular surface, because it shows impressions for many viscera. And I think the impressions are clear. This is the impression for the stomach, impression for the esophagus, impression for the duodenum, for the colon, for the kidney. And you can see on this surface, the posterior inferior surface, H-shaped groove formed of right limb, left limb, and connected by transverse limb. The right limb is formed by groove for the inferior vena cava and the groove for the gallbladder, while the left limb is formed by groove of ligamentum venosum and the groove for ligamentum teres. The left limb and the right limbs, which are grooves, are connected by transverse band, which is the hilum of the liver, or called porta hepatis, containing the bile duct, hepatic artery, and portal vein that are arranged in VAD arrangement. The vein is posterior, the artery is in the middle, and the duct is anterior, VAD arrangement. If you look to the H-shaped configuration on the visceral inferior posterior surface, formed by groove of inferior vena cava, groove for gallbladder, fissure of ligamentum venosum, fissure of ligamentum teres, both are connected by horizontal porta hepatis. You can have a knowledge that this region between the groove of inferior vena cava and the groove of inferior of ligamentum venosum, this part is called Quadrate Lobe. While this lobe between the fossa for gallbladder, or groove for gallbladder, and the groove for ligamentum teres, this is a quadrate lobe. And you can see that this quadrate lobe have a tail would continue with the right lobe. It is called caudate process. The caudate process represents the upper boundary of the epiploic foramen of Winslow. The caudate lobe is the interior wall of the omental bursa, the lesser sac. Fissure of ligamentum venosum and the hilum form the attachment of the lesser omentum to the liver. We said in the presentation of the peritoneum that the lesser omentum is attached to the liver to fissure of ligamentum venosum and porta hepatis, and this is the attachment of lesser omentum. Actually, the liver is classified to be formed of two lobes by the falciform ligament, and these two lobes are, this is the falciform ligament, are a small left lobe and large big lobe. And this small left lobe on the left side of falciform ligament and large right lobe are anatomical lobes of the liver. Accordingly, this is the caudate lobe is part of the right anatomical lobe. and this is the caudate, while the quadrate lobe also is a part of the right anatomical lobe. But there is another type of a classification that is dividing the liver as two equal lobes, which are called physiological lobes. The left lobe is same size of right lobe in physiological lobulation, and these two equal sized lobes are divided by the fissure for inferior vena cava and fissure or fossa for the gallbladder. Accordingly, the caudate lobe is part of the left functional lobe. Also, the quadrate lobe is part of the left functional or physiological lobe. Blood supply to the liver is 70% from the portal vein, 30% from the hepatic artery. An important note here that the liver is divided into many segments. Each of these segments is a functional unit. It is surrounded by fibrous septum, having its own artery, vein, lymphatics, bile duct. So you in disease, you may remove any of these segments of the liver without affecting the functions of other segments. Such segmentation had also been seen with the lung. Sorry for that disturbance. The last topic is the extrahepatic biliary apparatus. The extrahepatic biliary apparatus is formed of the following parts, starting from the porta hepatis, which is the hilum of the liver. It is formed of left and right hepatic ducts at the porta hepatis that are arranged in VAD arrangement, the vein posteriorly, and the artery in the middle, the hepatic artery in the middle, and the bile duct is inferior. The left and right hepatic ducts unite at the porta hepatis to form, number 2, the common hepatic duct. The common hepatic duct descends shortly and then unite on the right side with the cystic duct, which is the duct of the gallbladder. The gallbladder is a pear-shaped sac filled with bile lying in the fossa or groove for the gallbladder and the liver. And the gallbladder is covered inferiorly by peritoneum, while superiorly it is not covered by peritoneum because it is adherent to the undersurface of the liver. The gallbladder, which is pear-shaped, is divided into many parts. First, the fundus, which is part of the gallbladder projecting below the lower border. This fundus, as it projects below the lower border of the liver, it has a very important surface anatomy here. As it projects from the lower border of the liver, it will be at the level of the right 9 costal cartilage at the linea semilunaris. Linea semilunaris is the lateral border of rectus abdominis muscle in surface anatomy. So the point of meeting of the lateral border of rectus abdominis muscle, which is linea semilunaris, and the right costal cartilage is the site of fundus of gallbladder as it projects below the lower border of the liver. Why this is important? Because if the gallbladder is inflamed, as in acute cholecystitis, you may put your finger below the 9 costal cartilage at the linea semilunaris and you will ask the patient to take a deep inspiration. So when the patient will take inspiration, the diaphragm descends, pushing the liver downward, and so this fundus will touch your finger and the patient will feel very severe pain and he will stop the inspiration because of that. And that is called Murphy's sign. A positive Murphy's sign indicates inflammation of the gallbladder. So the first part of gallbladder is the fundus, second part is the body, then the neck. The neck of gallbladder continues with the cystic duct. The mucosa of the neck contains spiral valve that regulates the passage of bile in and out. The posterior medial wall of the neck is dilated, forming the so-called Hartmann pouch. This pouch in the posterior medial aspect of the neck of gallbladder is very important because many times you find the stone inside this Hartmann pouch. It is a site of lodgement of Hartmann of stone. After the Hartmann pouch, the neck is continuous with the cystic duct. And the cystic duct is very short, it's 3 centimeters in length. Its mucosa also shows a spiral folding, but the spiral folding in the cystic duct is not act just like a valve, as does the spiral mucosa in the neck. Cystic duct unite with the common hepatic duct to form the common bile duct. The common bile duct, as it begins by union of cystic duct and common hepatic duct, descend down in the free border of lesser omentum. On the left side of it is the hepatic artery, and behind it, both of them is the portal vein. Then the common bile duct passes behind the first part of duodenum. Then it will be embedded in the head of pancreas. And inside the head of the pancreas, the common bile duct will meet the pancreatic duct, the main pancreatic duct. Both of these will enter the wall of the duodenum, and inside the wall of the duodenum, the union of the common bile duct and the main pancreatic duct form a dilatation which is called Ampulla of Water. The Ampulla of Water opens into the middle of the second part of duodenum from the medial side, and this ampulla is opened into the mucosa of duodenum by an elevation in the mucosa which is called a major duodenal papilla. This elevation in the second part of duodenum mucosa is guarded by a valve which is called sphincter of Oddi. And you have to know that the bile duct, when it runs in that course, it could be divided into 4 parts. The bile duct above the duodenum, which is supraduodenal part. The bile duct behind the first part of duodenum, which is retroduodenal part. The bile duct below the duodenum inside the head of the pancreas, which is infraduodenal part. And the bile duct in the wall of the duodenum, which is intramural part. And thus the bile duct, the common bile duct, is usually described to be formed of 4 parts: supraduodenal, retroduodenal, infraduodenal, and intramural, which is inside the wall of the duodenum. After that, the common bile duct unites with the main pancreatic duct to form the hepatopancreatic ampulla of Water that is opened into the medial aspect of the second part of duodenum by the major duodenal papilla that is elevated here in the mucosa. This papilla is guarded by a sphincter called the sphincter of Oddi. You have to know also that the intramural part of the common bile duct, which is inside the wall of the duodenum, is also guarded by a valve which is called valve of Boyden. This description is the classical description for the extrahepatic biliary apparatus. These are called extrahepatic biliary apparatus because they represent the bile ducts outside the liver. So supposingly there are many bile ducts inside the substance of the liver that is called, or that are called, intrahepatic biliary apparatus. But now we have described only the extrahepatic biliary apparatus. Intrahepatic biliary apparatus is part of the histology of the liver. And even these extrahepatic biliary structure are subjected to many variations, so you should be aware of the variations if you will become surgeon in the future. Therefore, we must say something about relation of the common bile duct. As we say, the common bile duct is formed supraduodenal, retroduodenal, infraduodenal, and intramural. The supraduodenal part of the common bile duct is related anteriorly to the right lobe of the liver, but behind it is the portal vein, and on the left side is the hepatic artery. Retroduodenal part of the common bile duct is related anteriorly to the first part of duodenum, posteriorly to inferior vena cava, and on the left side gastroduodenal artery. Infraduodenal part is surrounded by the head of the pancreas, so it is anteriorly related to the pancreas, while posteriorly is related to the inferior vena cava. Thank you very much, and sorry for the disturbance.